afternoon and welcome to CSPC 2022 pre-conference. My name is Roseanne Alliong and I'm the Executive Director of Research, Innovation and Translation at the Baycrest Academy for Research and Education at Baycrest Center for Geriatric Care in Toronto. It's my privilege to serve as today's panel moderator. I'd like to first begin with a land acknowledgement. Although we are meeting virtually, we acknowledge that Baycrest operates on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis peoples, and is subject to the Dish with One Spoon Wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today, and you may live and work in different territories. So we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land.
Thank you very much. So our panel here today is focused on implementation of the first priority of the National Dementia Strategy. We've included a summary of the National Dementia Strategy in the chat feature of Zoom, so please go ahead and click on that so that you can download it. To summarize, the goal of the first priority is to discover new risk and protective factors for dementia, to promote adoption of effective interventions to reduce risk, to expand awareness of these risk and protective factors and interventions, and to improve social and built environments to increase the adoption of healthy behaviors. The National Dementia Strategy was launched in 2019, but its implementation has been slow, and I'd say especially for this first priority. Our goal in this panel is to crowdsource your ideas to implement this first priority, which we will collate your ideas and turn them into a white paper to disseminate broadly to help move these efforts forward.
I'd now like to introduce our distinguished panelists. To begin, Dr. Jane Rylett is the Scientific Director of the Institute of Aging at the Canadian Institutes of Health Research, CIHR, Canada's federal funding agency for health research. Dr. Saskia Sivanathan is the Chief Science and Knowledge Translation Officer at the Alzheimer's Society of Canada and a member of the Ministerial Advisory Board on Dementia. Dr. Nicole Anderson is the Associate Scientific Director of the Kimmel Family Center for Brain Health and Wellness, as well as a Senior Scientist at the Rotman Research Institute. Eliav Shaked is the co-founder and Chief Executive Officer of Redispec, a Toronto-based medical imaging startup in the Alzheimer's disease diagnostics field. Our fifth and final panelist is Jim Mann. He will kick off our panel in just 1 minute by introducing himself to our audience. But first, our panel is meant to be interactive as we crowdsource ideas from today's audience. Please use the Zoom chat function for your questions directed at the panelists. But at certain points during our session, our panelists will be posing questions to you to solicit your thoughts, ideas, and feedback. To engage with us today, we would like you to now open a web browser on your computer and go to the website menti.com. That's MENTI.com. When the time is right, our speakers will ask you to go back to menti.com in your browser and input a 7-digit code. That will allow you to input your feedback to each speaker's questions. We ask that all participants keep their answers brief and appropriate for a public audience. Thank you. So without further ado, Jim, over to you.
Thank you. Good day, everyone. This is a virtual conference, so I haven't had the opportunity to meet any of you, actually. So let me introduce myself. My name is Jim Mann. I live in Surrey, BC. I am 74 years old. I have an honorary Doctor of Laws degree, and I have Alzheimer's disease. So what do you see? Who do you see? And what's your focus? Do you zero in on my Alzheimer's as you look at me? Do you immediately think my cognitive abilities are limited? Do you wonder if it is worth initiating a conversation with me because you know I won't be able to comprehend anything? Do you even believe me when I say I have Alzheimer's? So let's talk. And let's look at the big picture of stigma for people living with a diagnosis of Alzheimer's dementia. An acquaintance of mine was a senior member at his golf club where he always ran men's night. He made the arrangements and collected the money, and members would ask him about rules as he was a fount of knowledge. And the day after members learned of his Alzheimer's diagnosis, they stopped asking him about rules. He no longer handled anything to do with men's night. It's so obvious, he said, that people are assuming incapability. We get challenged on our diagnosis. I was on a panel, and when the session ended, a doctor approached me and said he knew I didn't have dementia because of the way I was dressed. At a conference where a number of people living with dementia, including myself, spoke from a podium, a doctor questioned our legitimacy because, in his words, they look normal. So I ask you all today a basic question. How do we flip stigma on its ear?
So just to get us started, I'll say, please go to that menti.com and enter that. It's an 8-digit code that's at the top of the screen. And I believe the staff have also put it in the chat for you to copy and paste. We look forward to your responses. I believe you get up to 250 characters too. So we decided not to use word cloud because it's so open-ended. So feel free to elaborate a little bit too, if you'd like. These are great ideas. I wonder if the person who wrote knowledge sharing could elaborate a little bit. Jim, do you have any other probing questions? You are on mute right now. That I'm going to scroll down a little bit.
I am on mute, and here I was talking to nothing. So doctors in family medicine and their interactions with patients seem to be problematic, especially for people living with dementia across the board. And what are people's thoughts on fixing this wicked problem?
And like the person who asked, what have other organizations and diseases done? We all know that cancer used to be the C word and we wouldn't acknowledge it. I'm sure we could learn a lot from that group.
Yeah.
Media initiatives, good one.
The
too.
another question I might ask is, how might attendees suggest we overcome the presumption of incapability for people living with dementia? That automatic assumption.
Yeah. I like that one. Creating opportunities for people living with dementia to interact with doctors not as patients, but as partners.
Yeah.
Good one.
For a research project I'm co-investigating, we actually did a continuing medical education session for doctors. It's very interesting, the evaluations and the comments.
Yeah.
The presentation was very insightful for them.
Yeah, I bet. They're fabulous ideas.
I like that. We need to do open conversations about stigma.
Mm-hmm. These are fabulous. So we're running towards the end of this little session, but we want to capture everything that people have to say. So if we run out of time on this screen, please use the chat function. Both the Mentimeter responses and the chats are all going to be recorded, and we'll be pooling them all together in the end.
Thanks, everybody, for the comments.
Yeah. This was fabulous. Thank you so much, Jim. Okay. Hey, over to Jane. Oh, you're on mute, Jane.
Sorry, every time. Thanks very much, Nicole. We're going to change topics here a little bit, and we're going to talk about a life course approach to dementia prevention. So really, this is about reducing the risks for cognitive impairment in aging. And this can happen across the life course by changing or addressing a number of modifiable lifestyle risk factors. So what is the issue here? The issue, one of the main issues, is that there is unprecedented growth in the number of older people with clear implications for increased prevalence of cognitive impairment and dementia as we move forward. The numbers are already high, but predicted to get much, much higher, doubling about every 20 years if we don't find ways of addressing this. So at the moment, about 10% of individuals age 65 and older have some form of cognitive impairment or dementia, and that increases to close to 30, even 40% for those 85 years of age and older. And important to know that the age group of 85 and older, the longest living older adults, is the fastest growing age demographic in the Canadian population and many countries around the world. So what are we learning? Well, we're learning that risk factors and protective factors associated with acquiring dementia or cognitive impairment occur throughout the life. It's not just something that happens in later life. Throughout our whole life course, there are factors and that can be modifiable that we can address that can change the risk for cognitive impairment. So for a long time, it was considered that increased age was the risk factor for developing dementia. That's not true at all. This disregards all of the essential pathways that are grounded in biological and psychological and social contributions to how we age, and in particular, how our brain ages in this context. So the life course approach then underlines the need to study the long-term interplay between all of these factors and mechanisms from birth onwards. Adult health, for example, and disease risk can be linked to the physical and social exposures that occur during gestation, childhood, adolescence, adult life, and even across generations. So how does this look then? In the early life period, childhood and youth, looking at education and how this interplays with cognitive reserve can establish how the mind can resist physiological and pathological changes as we age and develop resilience. In midlife, there are a number of different lifestyle behaviors and occupational exposures or head trauma, for example, or depression that can increase risk for development of cognitive impairment. That includes things like heart disease, diabetes, metabolic syndrome. And all of these chronic conditions can impact our health in many, many ways, including our brain health. And so attending to these in our 40s and 50s and 60s can impact brain health as we age. So things like mental health and physical activity show huge patterns in terms of brain risk. And then in the later stages of life, still, there are a number of modifiable factors that can be taken into consideration. This includes social networks and physical activity and various other chronic conditions. So intervening with exercise and diet, not smoking, all of these things can play a role here. So what is the challenge then? The challenge then is, what are the best approaches that we can use to spread the word about dementia prevention in both early life and midlife, so that people consider this in terms of their health as they move forward through their life? What are the most impactful messages? So we're really looking forward to you as the audience in terms of giving us some feedback here. So how should we approach this? What are the best messages we could give to people?
I'd say especially people out there in the audience who are in your early or your midlife, what would resonate with you?
Exactly. And I see role models. Maybe you could expand on that a little bit so we understand who are the role models and how do they contribute the information. One thing we might also consider is, what is the best way of communicating? Is it internet sites? Is it television? Is it radio? Is it through community groups? What are the best ways of delivering the message, and considering the generational aspect of that? Yeah, I think that's a great example. Smoking cessation has worked quite well in getting the messages out. So what were the most effective ways that was accomplished?
I'm just thinking, I have an 18-year-old and a 20-year-old, and at that age, you feel invincible. So
Exactly.
how do we reach that age group to let them know that what you're doing now has impact later on in life? But
yeah, what are the messages that could come through the school system, the education system, teachers that they look up to, and or other role models to individuals in those age groups?
maybe we need a rap star spokesperson.
Yeah. The comment around support for healthy changes in life is important, because it's not, when you think about heart health and metabolic health and brain health, these things are all linked and all come together. So being able to portray it as an active lifestyle and engaged lifestyle, I think, is important as well.
Maybe in that context, for underprivileged people, how can we ensure that they can engage in an active lifestyle? Not everybody can afford hockey gear, etc.
No. I guess this is what comes then to policy changes, making opportunities available so that there are no people that are disadvantaged. So that is seen in the comment around government interventions that enable healthy lifestyles, affordability in terms of eating well, exercising, including healthy lifestyle and conversation. It becomes a part of our life.
Mm-hmm. Okay, perfect timing.
Okay, great.
Thank you very much.
Thank you. Thanks, everyone.
Yeah. Thanks, Jane.
Thanks, Nicole. So we've heard a little bit more about the importance of risk reduction. And I think we think about risk reduction in brain health as these large scale changes that need to be made to our lifestyle, big diet changes and exercise changes that need to be very big changes. But what we also know is it's incremental, and those small incremental changes as you build on them can be significant. The evidence also really shows that there are other factors that are specifically linked to dementia that can be addressed, other risk factors, things like hearing loss, better sleep, cognitive engagement, social isolation, as we saw very much through the pandemic. And so this brings me to the graph that you see here, which really talks and tries to demonstrate how essential it is that we address risk reduction and generally address dementia and the need to find better treatment approaches early on. So at the Alzheimer's Society, we recently published a report that looked at the state of dementia in Canada, and we looked at simulation models that projected the numbers over time. So we know that there are almost 600,000 individuals living with dementia in Canada, and by 2030, that number will reach 1 million. By 2040, that works out to about 29 people being diagnosed every hour. And when you look at caregivers, they're putting in an average of 26 hours of care per week, which amounts to about 470 million hours of care a year. That's 235,000 full-time jobs. So one of the key questions we asked is, what if we could delay the onset of dementia? What if we could delay it by just a year? As you can see in the graph, what happens if you could delay it by 10 years? And what you see is that if you could delay the onset of dementia by even a year, and risk reduction could be part of that strategy along with treatment options, it's just a simulation model, so we don't know what that could be. But it would mean that 500,000 Canadians would not be living with dementia by 2050. You would be able to reduce, you could avoid 500,000 cases. A delay of 10 years would mean 4 million cases could be avoided. So the question that I'm posing, and it's building on what Jane just asked, is what can we do to make brain health evidence not just accessible? So it's about getting that message out, absolutely. But how do we make it actionable? How do we get people to understand that these smaller changes over time and what those changes could be and how they can action them? What would that look like? That's where we'd really like to hear from you. And what have other fields done to be able to make those changes? We often talk about diabetes as a very good example in helping people understand how those lifestyle changes are actionable changes that you build over time. So we'd love to hear from you on that. And I think while we're waiting, the other thought I would add is that addressing risk reduction and it is also very much tied to it's very much tied to diagnosis early on, and we'll hear a bit more about this from Ilyev. Diagnosing at the right time and appropriately means better management. And a lot of those risk factors are not only related to reducing your overall risk of dementia, even after a diagnosis, continuing with those lifestyle changes can really also support that overall trajectory that people have. So yes, we're seeing starting early education on brain health. Absolutely.
Climate change.
Climate change. Okay. This is one that we haven't talked a lot about, but a very important one, and lots of evidence that really links to dementia there. Easy changes in messaging. Yes, getting your hearing checked. That's actionable. You can go to your doctor, talk to them about it. And then from a policy perspective, of course, we've talked about making hearing aids accessible from a cost perspective. And then, of course, the stigma around wearing a hearing aid and being able to address that. I see someone said, incentivize small changes, right? Mm-hmm. behavioral psychology fields, perhaps. Well, that's a good point. There's a field, quite a field of work around nudge, sort of nudging changes and research around nudge methodology. Maybe those are parts of where we can draw as well.
Oh,
Making screening more common. Oh, interesting. I'd love to hear more if the person who put that in could expand. What sort of screening are we talking about, and what would make how do we? There's screening around stigma. There's stigma around screening as well. We'd love to hear more. Change takes time. Early education is preventative. Making healthy nudging a part of technology development. Oh, that's an interesting thought. Could you expand on that a bit more? What would some of the tech development be around nudging that could be incorporated? And I can see the link between screening common and then, right, all the areas of prevention that could be routinely addressed, right? After you turn a certain age, we all get our screening done. And so incorporating those.
this one. Oh.
Go into long-term care or seniors clubs to explain evidence in a non-expert friendly manner. Right. Right. Very good point. To people to people who are living with. It's not just about the healthcare providers, right? That you can hold that action in your hands yourselves.
Somebody up here said, speak to all audiences and ages. Actionable steps.
Right. Yeah, it really builds on the point that Jane was making earlier around the life course approach. Makes exercise classes subsidized. Yeah, as part of healthcare coverage. Great point.
Yeah. Oh.
Right. So tech development is usually to achieve a certain behavior from the user. It's time we acknowledge it and embrace it. I mean, we've certainly seen that in social media, haven't we? And so why not embrace that as part of our tech? Great.
Oh, I like this. Families engaging in healthy lifestyles together.
Cross-generational. Yeah. Home diagnostic.
Okay, well, the tech development one is the perfect segue to the next topic, which is mine, because I'm going to be talking about national tech initiatives. So I'm going to speak about 2 dementia risk programs that I've been involved in, one that's at the national scale and one that's regional, to help get your creative juices flowing about how we can make programs like these more accessible across Canada. The first one is Brain Health Pro. This is a year-long, fully online, interactive, and engaging program available in English and French. It was created by nearly 100 scientists and trainee members of the Canadian Consortium on Neurodegeneration and Aging. Brain Health Pro offers 10-minute chapters 4 times a week across 7 known modifiable lifestyle risk factors for dementia. The chapters are professionally narrated and include goal setting, interactive activities, and opportunities for reflection. So in a sense, these kind of nudges. We are currently trialing it in 350 people across Canada, but intend to make it available to all Canadians in the future. And I would like to say that this was built in partnership with the Alzheimer's Society of Canada. The second one is the Kimmel Family Center for Brain Health and Wellness at Baycrest. This is the first research-driven community center specifically focused on reducing dementia risk factors. Members age 50 plus will come to the center and get a deep dementia risk evaluation, and then will be prescribed programming in the center to reduce their specific risk factors, including physical activity, cognitive and social engagement, brain healthy eating, and stress reduction. What we have in this center is really no different from what exists in other centers like the YMCA's. So there's a real potential here for us to spread this personalized dementia risk model across Canada. but how do we actually do that? So my question to you is, how do we make dementia risk reduction programs, both online risk reduction programs and real life or in-person ones, more accessible across Canada? So I look forward to your contributions. Building on existing initiatives. Yes, I totally agree. Plan for sustainability using evidence-based tools. Get them into where communities are. Completely agree. How do we do that? How do we get into, there's so many individual communities across Canada. And something that's really, that I wake up at night and think about is, how do we get into rural communities? You know, so some communities don't have internet access. How do we still reach them? They might not have a community center. Diverse communities access services differently, meeting them where they're at. I like it. Franchising support. That's a great idea. They can tailor it to their own communities. That's fabulous. Yeah, like we created the brain health food guide, but it's just general. How that's actually implemented into different recipes would look very different across cultures. I like that idea a lot. Subsidized programs would reduce cost. Absolutely. We're looking in the Kimmel Center to provide free memberships. It's tough, right? Because you're always dealing, we will do it, but we're still figuring out how we'll do it, because we still have to make the center not profitable. We're not looking for that, but breaking even. So I think, is that donor money? What is that? Train liaisons to bring initiatives to other existing centers. Great idea. Pipeline to adapting to different communities in a co-creation process. Yep. And replicate. I like the co-creation. I should have mentioned that Brain Health Pro was created with the Citizens Advisory Group, a group of 9 older adults who reviewed all the material and made sure it was appropriate. But when it's adapted to different cultures, we need special groups to ensure that. And we do have advisory co-creation groups with the Kimmel Center too. That's so important. I like this idea of building a model and finding liaisons. Yeah. No-brainer business case for why it's important to invest in. So this sounds like a business person. I would love, my email address will be at the end of this presentation. Please reach out to me because I have no business background. So building business cases around prevention is, we need this partnership between business and our dementia risk reduction efforts. Tell people about it. People don't know programs exist. Non-traditional stakeholders help fund and support industry, wellness centers, gyms. Yeah. Yeah, there's a lot of places now focusing on brain health for seniors out in the community, but they're not necessarily evidence-based. But I think if we could form partnerships where we could say, we can bring the evidence and help you make it truly evidence-based, that I think they would love it, and it would improve the situation. Research, government, lived experience groups. Yes. Yeah. Central place to access the program. That would be great. Like have a, what's it called? like a storehouse, warehouse of a website, at least. If you live here, you can go here or access this. Less general program, very focused on brain health. Yes, yeah, the library of programs. Just checking the time, last minute here. Yeah. All of your ideas are so fabulous. This is great. I can't wait to put them all together. Okay, I'm gonna move on next. Thank you so much. And hand it over to Eliav.
Hi there. My name is Eliav Shaked. I'm CEO at Retispec. Thank you so much for having me here. I'd like to just allow me to picture this new world that's coming right now. Over the next couple of months, we're going to be finally introduced to an effective treatment, Alzheimer treatment. This is something that's going to be introduced over the course of 2023 as well. This would greatly facilitate the use of biomarkers for early detection, for accurate detection of Alzheimer's disease. Despite having, one of the expensive universal healthcare systems in the OECD, Canada is particularly Ontario, has really a big problem. Primary care settings are not equipped to effectively assess cognitive analysis or diagnose Alzheimer's disease. And that results in a lot of individuals that are underdiagnosed and downstream impact on those with AD, with Alzheimer's disease, their care partners, and the broader healthcare system. So over the coming years, Canada is projected to have longer wait times for Alzheimer's treatment than any other G4 country. This is due to shortage of dementia specialists and also to the availability and the accessibility of the diagnostic tools such as PET scan or cerebrospinal fluid analysis. So it will be impossible to actually sustain this due to the high cost and long wait times to access any care and actually get the prescription for the drug that is already available in the market. So given these challenges in diagnostics and screening for Alzheimer's disease, an assessment of cognitive status in primary care setting, we must change the narrative. We must explore new solutions to alleviate the burden on primary care and to ensure a timely screening for adults with memory complaints who are likely to benefit from this treatment. I'd like to also share with you an exciting project that is actually now live in Ontario. This project implements the world's first screening for Alzheimer's disease that leverage collaboration with optometry settings and local Alzheimer's Society chapters that enables accessible identification of individuals that are at risk for Alzheimer's disease, and then refer them for qualified clinician, facilitates faster diagnostic. And this is something that's going to be available in the community and in several locations in Ontario. We want to test this and actually present this to the World Economic Forum in less than a year and share a new future and a new way to implement and help healthcare system prepare to this avalanche and to this dire problem that we're facing right now. So with that, my question to you is, how do we prepare healthcare systems and provide and providers with solutions for early detection and treatment that is already knocking on Canada's door? That is great. We need to make referrals much easier. We need to make sure to streamline that process and make it more accessible.
Well, it won't reflect on Mentimeter because I can't multitask that well, but I think we really need to educate primary care doctors, family doctors about dementia and dementia risk and early detection. The feedback I get from a lot of older adults is when they go with cognitive complaints, their doctor says, well, you're 72, what do you expect?
Exactly.
Yeah.
They also had their medical school about 70 years ago.
Yeah.
So we need to really understand what's the problem is and how they are integrating innovation and solutions and actually helping healthcare system prepare for a drug in the market, because they live in the world where it doesn't exist.
I like the idea. Is our remote scans? Is there a remote ready spec?
Yes, there is.
Wow.
It's an eye examination. You can get it in your optometry. We could put it on an RV and get it scanned in your community. You actually do such work in the US. So it's something that should be accessible and equitable and provide access to this in the lowest barrier possible. It should be in Shoppers,
Yes.
in Costco for that matter.
We have access to other specialists, not just family docs. Yes.
Exactly. We should provide this referral system, as was mentioned here, and also accessibility in the most lean and way possible, and also in the way that individuals are practicing and are getting healthcare provided to them today.
Mm-hmm. Increase funding for neuroimaging and biomarker testing.
That is great, but you also need to notice that these PET scans are primarily reserved for oncology and also for vascular cardiovascular diseases. So the lineup is just going to continue to grow and grow, and as you can see, the projected wait time for imaging or to be referral for a dementia specialist today is very high, and it's going to be projected by 2025 to be between 60 to 80 months wait time. So this is something that has to change. Getting awareness on the latest research and implementing this is something that's quite exciting.
So when I was referring to a remote eye scan, do you see in the future that somebody could hold their tablet and I guess the light would be bright enough?
Yeah, you have
inside the eyes?
you have great innovation that's coming from digital biomarkers, companies that actually could allow you to detect cognitive impairment in the palm of your hand through an iPhone. You also have, but you need to confirmation of the pathology. And that is something that instead of having a large PET scan or cerebrospinal fluid analysis, could be done through a retinal examination in a non-invasive and very affordable way. And also through a blood test that could be accessible through those dementia specialists. Mm-hmm. Obviously, this is primarily an issue that is going to be a mix of all these incredible innovations coming together, and healthcare system must be ready for this, and policies need to be implemented and piloted across Canada.
I like this. Recruitment and retention initiatives for medical technicians, physician. Yeah, wow. That's another huge issue, that just 100%. The labor issues right now. Yeah. Hopefully that will rebound as we get past the pandemic. No easy, central, straightforward way to bring evidence to physicians in Canada. I don't know if they all read CMAJ. We could be sure to publish there as much as we could. I don't. Medical librarians. Yeah. To bring the knowledge in a digestible way to physicians. Or even if they had, when all my doctors they're on their computer, they log in when they start to see me, like the latest news about something popped up. I don't know, they probably you rely on multiple and varied sources of information. So I think the message there is we have to get the message out in multiple and varied ways. Okay, well, time consuming and labor intensive, but worth it. Okay, so
thank you.
All right. what is going to happen now is that I would like to thank you all very much for your input. And at this point, Roseanne is going to be reporting back to us on what she has heard from all of you, one question at a time. Please continue to use the chat function. I have not had time to monitor it, but I'll start to look at it now. To point out any additions or clarifications, if she didn't hear you quite correctly, be sure to point that out. And even if we miss some of your comments live, we'll have the recordings of them in the chat, and we'll be sure to implement them down the road. So it's turning it over to Roseanne.
Hi, everybody. Sorry, I was frantically whiteboarding in the background. So what you see on your screen is actually the ideas as they appeared to me, and how I essentially whiteboarded and tried to summarize everybody's ideas. So again, echoing Nicole, please don't hesitate to pop ideas or in the chat that I got right, that I got wrong, things that it spurs for you. So this is an answer to Jim's question: how do we flip stigma on its ear? So what we're hearing on the left is my raw, essentially, whiteboarding. We're really focusing on knowledge sharing. So sharing stories, sharing lived experience, using alternative approaches like through the media or artwork. That goes hand in hand with education and information. So people also mentioned using, community-based resources like community centers or senior centers to push, ideas and destigmatize in the community. Open discussion. Really about stigma and acknowledging the truth of dementia. And that goes hand in hand with an emotional component. So, for example, empathy, openness, a lack of judgment. And then also an emphasis on action. So how do we demonstrate action and engage in life? And we interact with individuals living with dementia as partners and not patients. So what you see on the right is our bare bones summary around knowledge sharing, around education, around awareness, around empathy and emotion, and around open discussion and an openness in terms of how do we, I'm advancing slides. I go back. Give me one sec. How do we flip stigma on its ear? So I just want to take a pause there, see if people want to pop things in the chat. If I got things right, I got things wrong, if it spurs any new ideas for you. And Nicole, you let me know when I'm ready to move to the next summary.
Okay. I don't see anything yet, but you just put out the invitation, so let's keep an eye.
Okay.
A second. Just Inbal saying that we should do this panel again elsewhere.
Pardon me?
Inbal saying we should do this panel again elsewhere.
Okay. Well, we could take this on a roadshow. All right.
Okay, so I think you must have reflected it very well.
Okay.
So I would go ahead and move on to the next one.
Okay. So the second question posed by Jane was, what are the best approaches to spread the word about dementia prevention in early and midlife? So on the left, again, you see my kind of raw whiteboarding and sort of a focus on spreading the word. So we see, for example, on the left, role models, incorporating prevention into our lives, resonating with younger individuals, AKA start young. We also see, for example, a healthy lifestyle in conversation. So really an emphasis on incorporating it into our lives. On the right, you start to see focus on emotion. So focus on the benefits and less on shame. We also see how do we communicate in terms of vehicles. So learning from other campaigns, focusing on social media, incorporating community champions. And that can include, for example, community and fitness centers, schools, podcasts, and traditional news. And then on the top left, you see supports. So really an emphasis on that we do need support in order to do this, whether that be government supports or other resources to make this affordable and accessible. On the right, you actually see my summary. So again, on the left, really focusing on role models, thinking about bringing it into our daily lives, whether focusing it throughout the lifespan or focusing it within our existing conversation. On the right, appeal to emotion, learn from other campaigns, focus on supports, and then really think about a multimodal approach in terms of the vehicles we use. So schools, centers, social media, champions, traditional media. And that really leans heavily into a lot of the implementation science, for example, that many of us work in. So I'll take a pause there and see if there's feedback, things I missed. How do people feel? And I apologize, I'm looking at multiple screens and multiple places.
I just wrote, we need a Greta.
Oh, Thunberg?
Yeah, yep.
Yes. Yes, we need a Greta Thunberg. How do people feel? Did I forget anything? Is it representing people's thoughts?
Well,
Nicole?
Roseanne, this is great.
Okay, do I keep going, Nicole?
I think so. Yeah.
Okay. So our third question was, how do we make brain health evidence not just accessible, but actionable? So on the left again, you see my raw whiteboarding. So a really big focus on early education and across the care continuum. An idea about bringing hope. So there was a discussion about climate change. So how do we actually think about a broader initiative around climate change, its impact on brain health, and how do we bring hope to a younger generation? Also, a big discussion on tech development. So can we promote behavior change, healthy nudging, diagnostics through technology? And how do we actually think about screening? So there was a lot of discussion about hearing checks, easy messaging, making it part of annual physicals, not just later in life, but throughout the lifespan. Incentivization, so focus on small changes, focus on small benefits. Power to the people, so really bringing it to the people and to individuals, using a lay-friendly approach, taking an intergenerational approach, making it a whole family affair on how to make brain health a priority. And then again, a common theme about supports, recognizing that we might need, for example, healthcare coverage or subsidization in order to make this possible. So again, on the right, the overarching summary. So education, screening, incentivization, a focus on power to the people, tech development, which could also lead to broader supports. So I open it again to the floor. Did I get it right? Did I get it wrong? Please add in. Nicole.
So this is really important. Inbal said, I think we need a much more strategic approach, much better coordination of all the prevention efforts that exist out there at the national level. Otherwise, we are not being efficient with limited resources, which is a fabulous point, to which Danielle Oliveri said, right, increased collaboration is missing. So maybe like the CCNA is the right kind of network, maybe, or together with the Alzheimer's Society and CIHR, all of these national initiatives, if we get together and all agree on what's our coordinated strategy here. Because I agree, if everybody's doing their own little thing on their own, that's not going to be effective.
So rest assured, I'm going to add a new box between supports and power to the people on the right around coordination of national initiatives.
And PHAC too. Yeah, or sorry, I know we're not supposed to say PHAC. That's like p-hacking. FAC. Yeah.
Yes. Okay. All right. Thank you so much for that feedback. Okay. Moving to the next slide. How am I doing for time, Nicole?
You're doing good. We're at 54.
Okay. So how do we make dementia risk reduction programs accessible across Canada? There was lots to be said. So on the left, again, raw whiteboarding, access across Canada. So a big emphasis on meeting them where they are. So for example, that includes co-creation, thinking about franchising supports to different communities and then allowing tailorization in those communities. Really big emphasis on stakeholders. So whether that be non-traditional stakeholders, collaboration, and that actually also on the right, you see hub and spoke model. So there was a great idea about training liaisons to then move into communities, for example, setting up a pipeline. Again, a common emphasis on resources, subsidization, other like a library of resources. And Nicole, you made a particular call out for somebody to reach out to you about business cases. So that also leads to an accessibility model. So on the right, again, a much more summarized approach. So meeting them where they are around co-creation, business case in terms of franchising, tailorization, resources and supports, whether that be a library, evidence-based tools, subsidies, leveraging existing initiatives, partnerships, non-traditional stakeholders with a focus on collaboration. And then the hub and spoke model potentially around liaisons and pipelines. So I'll take a pause there. What I get right, what I get wrong, please add in.
We got a question or a point. Jane said the new CIHR Dementia Research Funders Alliance can help address this. Saskia said supports is too broad. I think specific policy changes that enable those supports. That's a good idea. To which
I love Daniela's comment, policy specific support, actionable support.
Yeah.
And support's in the middle. Thank you, Daniela.
Okay, that's great.
Okay, I hope someone's recording this because I'm talking, I can't record it.
And all the chats recorded too, so we're going to put it all together.
Okay, perfect. Thank you. This is what happens when you crowdsource, Nicole. Okay, I'm going to actually exit out and actually restart because Monique has actually been prepping it in real time. So I just need to, give me 1 sec. Here we go.
Let's try to do this one in 1 minute.
Okay, let's do it. Let's do it. Sorry, give me 1 sec. Okay, fifth and final one. So preparing systems and providers. So what you can see is a big focus on the left in terms of awareness and education of providers. So exposing them to research, partnering, moving our faces, partnering with medical librarians, centralized repository. Up top, and that also leads into integrated KT. So emphasizing research and health authority partnerships, a focus on the system, access to specialists, earlier referrals, recruitment and retention of providers, a focus on remote. So mention about remote scans, remote care delivery, the availability of technology, and then a big piece on advocacy. So funding for imaging biomarkers and testing, resources, and broader capacity. So because I literally did this while we were like running between reporting, there's no summary, there's just raw. I'm going to open it up to the floor. Nicole, am I within time?
Yes, perfect, within time.
Okay.
Please put comments in the chat about this one. I think we should move on to the open mic and Q&A session. So that would be the next slide. And I believe that the CSPS have opened up people's mics and cameras if you'd like to ask any questions or make other points that we did not catch today. Anyway, you had fabulous ideas throughout, but maybe something's come to mind in the meantime.
And we have 2 minutes left, Nicole. Plenty of time.
I would like to thank everybody and spend some time doing that.
Okay. Should I advance slide, Nicole?
Sure. Okay, so I would like to very much thank all of my esteemed panelists here, Roseanne, the amazing facilitator, Monique Chang, who's in the background helping out, making these slides in real time, our CSPC liaison, Sharika, who was a great help in getting us ready. And I would finally like to thank all of you, the audience members, that we came here to crowdsource, and that's exactly what we did. So thank you very much. Look out for our white paper that we will be working on. We'll be sure to incorporate all of your comments, and if you have more, feel free to email me, and we'll include those too. So there is going to be a poll that will be launched at the end of this, so please respond to the poll to help improve CSPC, and look on their website for the schedule for both pre-conference sessions as well as the conference sessions coming up. So thank you.